Health Minister.
Deputy Andy Howell, Assistant Health Minister.
Ruth Johnson, Director of Health Policy.
I'm Andy Weir, I'm the Director of Mental Health, Social Care and Community Services.
Mark Carey, Deputy Head of Finance Business Partnering for Health.
And online.
Chris Bang, Chief Officer.
Thank you for joining us. I'm pleased we managed to get the technical issues sorted.
I do apologise not being with you today, but it's been unavoidable. I'm sorry.
We understand, thank you. And we have several members of the public viewing today. Thank you for attending. If you could also make sure your devices are switched off and that silence is maintained at all times. Thank you. Okay, so we are using this hearing as our quarterly public hearing, but we also have some questions around our budget review. So we have compiled the two to make best use of the time. That does mean that we have a lot to get through today. So it is very important that answers are kept succinct. And if we need more information, we will ask for more. Minister, we're going to open with an item about the Jersey Recovery College, which was highlighted in the media recently. Could you clarify whether the closure of Jersey Recovery College, whether before the closure, whether they approached you and asked for any additional support before that decision was made?
Yes, the first approach came during January before my appointment, and I first became actively involved with discussions on the 8th of March, if my memory serves me correctly. So there have been ongoing discussions since the beginning of the year.
And what support did you offer to them?
The detail of that I'll have to Andy, because he'll have a better memory of the precise figures involved.
So to begin with, we met with them on a couple of occasions to talk about sustainability and how we might work with them to make them sustainable. There was a concern in January that they would probably fold. We did a number of things. Their contract was due to expire with us in June, anyway, at the end of June. So we talked about a different contract for a year that would give them additional financial support.
And this was in March, did you say?
In March, yeah,
okay.
From March onwards. We agreed with them that we would significantly reduce our demand for activity but maintain the same level of financial investment. So the amount that we were paying for activity remained the same, but the activity significantly reduced. Mm-hmm. We supported them through our commissioning arm to work with the Jersey Charities Fund to get some support from them. It's important just to contextualise that the Jersey Recovery College, half of their work was funded by HSS and half of it wasn't. It was other work that was funded in different ways. And we'd already started a conversation with them about a different model of delivery for HCS. And we worked with them to agree that we could deliver that from the end of June onwards. We continued to fund their summer school in order to allow that to run, even though we weren't sure where we were going to go. And we agreed that we would provide some HCS staff, some mental health staff, to help them deliver the groups that they were going to be delivering in this new arrangement. And we did all of those things. So those things were just starting to get up and running at the point at which the announcement was made that they were unfortunately not able to sustain.
And was there any thought given, Minister, to giving the charity more certainty rather than just a 1 year solution? I know that other charities have raised this repeatedly and it's a common issue. Is that something you considered?
I like to think we looked over the course of those months at just about every option that we could. But I think when a point comes where you can see something isn't working out, you have to allow that situation to develop.
What specifically wasn't working out from your point of view?
Well, you've already heard that we were arranging to having a consistent amount of money for a reduced service. There's a number of factors that sit behind this that have led to the situation that we've got.
And what are those factors?
It's a little bit difficult. The way that the charity was structured, it wasn't going to deliver going forward the sort of service that was required for the money that was available, if I can put it in those terms.
Mm-hmm. What service were you asking the charity to deliver?
I'll hand back to Andy for the points of detail on the service.
I'd just like to hear a bit more from you on the points that you've raised.
Well, I think it's safe to say, without going into too much detail, because there are people involved, that are working with the team over a period of 6 months. We did everything we could, and at the end of it, we took the decision that what happened had to happen. Does that make sense?
Were there any solutions that the Recovery College team suggested to you that you declined to?
No, they made some
pursue?
series of suggestions and we ran with that, and those suggestions didn't really come properly to fruition in a way that was required for it to be sustainable. Bearing in mind that we have budget deficits and we've got to be, it's very, very easy to be critical of not saving everything and everybody. But we, as you know, have got considerable financial pressure and have to be extremely careful about the way we spend money.
Can I just clarify your answer there? So were there any potential solutions that were proposed by Recovery College that you decided not to pursue?
Offhand, I cannot recall anything that looked vaguely workable.
So I can help
Yeah,
with this.
if you want.
So in relation to the first part of the question, we were very given, we sought legal advice as to the duration of the contract, because we originally had planned to move to a 3-year contract. But actually, because it became known to us in January that there was a financial sustainability issue, we were having to put special measures into the contract for them at the start of 2024. The legal advice was that we could not do anything other than a 1-year contract, because it was a sustainability proposal for a year to see if we could make it work. They proposed that they should novate the contract that they had with HCS to another charitable organisation. The legal advice was that you cannot do that. You cannot, as a provider, simply novate your contract to another charity. So they did propose that early doors in the discussions, but it was ruled out as an option.
Because of legal advice?
The advice we were given was you simply cannot novate a contract in that way to another provider.
Could you just give us some detail on what that legal advice
Not from the top of
basis
my
on?
head, I would need to go back and look at that.
If that could be provided to the panel, that would help us understand. Thank you.
Minister, when you were considering that situation over those months, you would have been considering presumably the service that was provided and the value that you were, the value for money of that service, and alternatives that would have to be put in place somehow to provide that service. Was it in your mind that keeping this organisation doing this would be a simpler and more effective way than trying to create a new service?
I think common sense dictates that when you've got an up and running charity, you do everything you can that's practical to maintain the existence of that charity. But I'll make the point again that when you reach a point where you'd have to take a judgment, that judgment was made, and I'm guided by a team of professional people, then the decision was made that that was where it should end.
Had you had time to put in place measures to pick up the services that would be lost?
Not on a back-to-back basis, but once again, I need to hand over to Andy for the details of what's actually happening now going forward to replace the service.
So during the last term, 79.5 hours of courses were provided over 4 months. So that's the equivalent of 4 hours a week of activity. So we are in a place now where we are able to deliver more than that from within HCS within October. What we've done is, because we'd already started the work with the Recovery College around a future model, and a future model particularly that potentially involved partnerships between mental health staff in HCS and the Recovery College, we've just been able to accelerate that and build upon it. So we've got a plan from October to deliver more than that in terms of groups, but actually we're then going to grow that incrementally. So tomorrow afternoon there's a workshop involving people who use services, some of our partners and people from within HCS to look at how do we want to do this, particularly focusing on the parts of the work that were commissioned by HCS for HCS. The particular change that we were talking to the Recovery College about was having more of a focus on serious mental illness and a focus on groups and activities, particularly for people who use secondary mental health systems who weren't hugely represented in a lot of this activity. The other half of the activity was very much about education around mental illness, reduction in stigma, workplace mental health, that type of stuff. So health promotion, health awareness in the form of mental health. We've not taken much of that on at the moment, but in the end, we will work with other partners to think about how do we replicate that.
So the other partners that you've mentioned, Mind Jersey, if there was not a legal way to simply transfer the contract, why was another option not explored? If that charity was willing to take it over, why was another way to do that not found? Can you?
No, as I say, you've got to bear in mind that I think the legal advice actually predated my involvement. So, as I say, Andy's explained that he's had legal advice, and I wasn't aware that there was another way of getting around the problem. If you've got any suggestions, I'm sure we'd be pleased to hear them. But Andy's fairly comprehensive in the way he deals with things, and I do have to trust professional people.
Would you like a glass of water, Minister?
No, thank you.
If I understood you correctly, some of the services have been taken in-house effectively. Those would be the ones that were provided for the government. So you're now going to provide those in-house, but presumably that leaves still to be picked up the services that were provided not for government. Is that correct?
So part of the problem, I think, is that those services were services that were commissioned often by individual people. So, for example, there were mental health workplace courses that the Recovery College sought to sell to business and to the finance sector, etc., etc. Whether or not people want to buy that currently is a different issue. So we need to work out what we want to re-provide in terms of the overarching health promotion, mental well-being, reduction of stigma around mental illness type activities that were run by the Recovery College. Absolutely crucially to all of this, we'd done through the Mental Health Partnership Board, which is a strategic board with all partners on, including the Recovery College, we'd done a superb piece of joint work looking at developing a framework for how we co-produced and co-delivered mental health services. That's going to be integral to the work that we do now moving forward in the replacement of the Recovery College, because that mustn't get lost in all of this, I think.
Thank you.
Can I broaden the questioning slightly to third sector organisations generally rather than the Recovery College, and ask the Minister whether he agrees, first of all, that third sector organisations play a really important part in the provision of health services.
I'm happy to answer that and say yes, very, very, very much so.
And
Absolutely.
sometimes, indeed, they do it better than the health department itself might do them.
Very often charities are manned by people who have personal experience of the areas of work that they're dealing with, and I think they do, by and large, deliver great service.
So, I mean, do you think that HCS, generally speaking, has a sufficient understanding of the way in which third sector organisations work?
In the main, yes, but I think in this particular instance, given the options that were available, I think that we could end up having a better service now than we would have had under the previous circumstances.
Right.
If that makes sense. And it doesn't change the fact that at some point in time, as things develop, that activity might go back out to a charity at some point. We're going to keep an eye on how this provision works, and if at some point the decision is taken that might be better provided by a charity, then that's something we would consider. The work that's going on at the moment is work to make sure that we fill the gap.
Right. I mean, I asked the previous question really following up a question from the chair as to the period of time for which contracts are given. And I mean, would you agree that it is really quite difficult sometimes for charities to operate on the basis of 12-month contracts?
It certainly is, and I think one has to also bear in mind the fact that behind the scenes, with the economy having changed, with the Ukraine war, with COVID, all of these things have brought about a situation where the money that used to be donated to charities has dried up significantly. I think all charitable sectors are finding that private funding is drying up, and increasingly charities are coming under pressure. And it may be the case that we're going to see some charitable consolidation, which I think would be no bad thing, which reduces costs and reduces unit costs. So that's a possibility going forward. I think that'll be a natural progression.
Thank you.
And can we just confirm that the political decisions that were taken around this, did you take them as Minister?
We took them collectively. We discussed on a number of different occasions. Yeah.
And when you say we, is that you and Com or you and...
Well, I can't remember.
Politically, not officers.
Politically, that's how we've got a political team. But those decisions are obviously taken in conjunction with the professionals that are providing the background service.
And at any point was a conflict of interest or potential conflict of interest raised around your involvement with a mental health charity?
Everybody seems obsessed that I support a mental health charity. No, I've said time and again there are no conflicts of interest. I've been to the Commissioner and I've had the Commissioner write to me to confirm that he's very happy about the way things are done. I know everybody seems obsessed. Every time I come here I get asked questions about conflict of interest. There aren't any.
Because it's an important thing and there's also perceived conflicts of interest.
I tell everybody every time the question's asked, there are no conflicts of interest.
So, for the record, there was none declared in the decision-making process. You didn't declare a conflict or potential
No,
conflict of
I don't need
interest?
to declare a conflict of interest because everybody that I deal with knows full well, and we're frequently reminded.
Yes, I think we should. Just in terms of conflict of interest, the code of conduct is quite clear that even a perception of a conflict of interest, something that might be perceived as a conflict by a reasonable member of the public, should be declared, and that is best practice. So I would hope that you can
Thank you for
take
the reminder,
that
but
on
I have
board.
been to see the Commissioner and had it confirmed. I can forward the letter to you if you wish.
Please do, yes, thank you. Thank you for your answers. We're going to move on to the Dementia Strategy and Implementation Plan. I believe that you're here to assist with the answers, Andy. The implementation plan for the Dementia Strategy states that funding would be required to deliver and develop a proposal for a brain health island plan by March 2025. Has sufficient funding, Minister, been allocated to meet this target date of delivery?
Well, the budget for next year hasn't actually been defined yet, so that's a process that's taking place between now and Christmas. So that'll be defined, and at Christmas we'll know where we are with that.
So if the budget, as it is in draft form, if that's approved with all of your bids that made it into the budget, if that's approved, is that sufficient funding to meet that target date of March next year?
Like I say, those decisions haven't been made in detail. They're being made over the course of the next 12 weeks, 14 weeks. So we'll know what that budget is when there's a breakdown at Christmas.
Okay, I'll just ask that again. So if the budget is approved, does it contain sufficient funding to meet the target date of March 2025?
And I'll repeat my answer. If we're going to have a budget of X amount of money, the division of that money takes place between now and Christmas. And at Christmas we'll be in a position to let you know as to what they'll be available and what that's going to achieve.
Okay, so when you go
I'd say I'm
through
hopeful.
the process of allocating growth bids in the Council of Ministers, you've obviously made growth bids. One of those is around the dementia strategy, is that correct?
It forms a part of quite a complex budget process, yeah.
Okay. And if that's approved by States members, are you confident that that is sufficient funding to deliver the dementia strategy by March next year?
Insofar as we've committed to it, I'm hopeful.
Is that a yes or a no?
It's a hopeful.
I'd like a yes or a no, please.
I'm hopeful that we can deliver that. I'll answer the question. If you really don't know how to answer your questions, I'm hopeful that we're going to get that situation. That's as far as I'm prepared to go.
The Memory Assessment Service doesn't rely on money being allocated in the budget because there was a target to get to 6 weeks waiting time by October this month, by October this year, next month. Are you on target to get that waiting list down?
Best of my knowledge, I think that's been exceeded, but I'll pass you on to Andy for details. Yeah.
The team have done a superb job. We did a piece of work in the early part of the year where we looked at a trajectory for delivery against this objective. We have put in a small amount of additional resource, and crucially the team have worked differently in order to achieve the target. We're now at the end of August. We've gone from, in December we had 171 people waiting, and they were waiting for 124 days. At the end of August we've got 66 people waiting, and they're waiting for 53 days. So we've achieved that in advance of October, and I'm confident that we'll sustain that delivery.
Thank you, that's great news.
Could you give your view, Andy, on the March 2025 delivery date? Do you think that's achievable with the funding that's being bid for?
So I think that the implementation plan sets out against each of the 20 actions where money is either available now and things can be done within resource, or where additional resource is going to be done, is going to be required. The biggest one actually is one of the ones that you've picked, which is the delivery of the whole brain health service, which is far bigger than anything that we've got now. I think that my understanding of the plan is that we would develop the model by the end of March, and then we will need to cost that and understand what does that look like. So I think realistically, because of the way that things work, we would probably start to plan for an implementation date of next year for that service. Also, there's other tricky factors like staffing it and all of that other stuff that comes with new services. But I think for each of these actions, some of them can just be done, like the reduction of the waiting list, and we don't need additional resource. Some of them we're going to need to plan that resource over the implementation period of the strategy.
Yeah, and I know that you've spoken recently about the increase in demand for these services. how much of an understanding does the department have in terms of what that increase in demand will look like? Like, how able are you to plan for that in advance?
So we've got figures. So we've got, there's some our colleagues in planning did some good work as part of the strategy, giving us what we think the dementia trajectory looks like. So what we really need to start to unpick now, and it's included in the strategy, is what does the workforce plan look like in association with that? So, in 20 years' time, if the number of people with dementia on the island has doubled, we're creaking now in terms of particularly social care workforce. So how are we going to make that work in 20 years' time? That's the type of work, I think, that goes beyond the time frame of this strategy, but is so important in terms of delivering moving forward.
One of the things that I'm interested in is family carers, and the training was due to begin last month, I believe. How is that going? So
I don't know, actually, and I will find out and let you know. Some of the stuff that's delivered in this strategy is delivered by partners. It's not everything by HCS, clearly. So I'll get a specific answer for you on the training. I know I spoke to the Chief Executive of Dementia Jersey recently, and she was talking to me about they've got a new training offered, but I can't be confident as to exactly where it's at.
Okay.
Can you provide an update on the development of the new integrated model for dementia health and social care service, and whether, in particular, whether you have funding for it?
So we've only just started that piece of work. So to contextualise this, there's a programme lead who is employed specifically to deliver those 20 things in the scope of the implementation plan. She's been obviously prioritising the work and trying to get things up and running, particularly with partners. And there's no overarching steering group that looks after this, but we've only just started the work on the model. We've got funding now because we deliver dementia services now. So we have bespoke dementia services, we have dementia services delivered from within community mental health team for older people particularly. We have funding for some charitable work. So there's money in the pot. What the new model will look like and whether that's entirely funded by what's available today, we don't know until we've done the work. But I think it's the thing, particularly the carers that were involved in the development of the dementia strategy, it's the thing that they most talked about really. About the model in terms of how we divide up services and deliver them currently doesn't really work for carers, and they particularly push us very correctly, I think, in the steering group to talk about how can we do this in a more coordinated way.
What's your timetable if that work's only just begun?
So let's have a look and see what's in the plan. Could you point me to it, because that's the. Okay, so it's by May 2025. So the model says that we'll develop a new integrated model across the health and social care that embeds continuity support for people. That's a helpful prompt to me. By May of next year, and that continuity of support is particularly the thing that people most spoke about.
So are you on track for that?
So we've started the work. I'm sure that we can have a model developed by May next year. Yeah.
Okay. In terms of the organisations that would partner with government, you've just mentioned, Andy, that they would be critical. Minister, what work can you do now, and maybe taking some learning from the Recovery College, to make sure that those organisations have all the support they need to deliver in partnership with government some of these services?
Are you talking the general
Dementia organisation? Yeah.
As I say, I don't think we've got a similar situation with the dementia charity in any event. Not to my knowledge. I think that's all very secure. So
I'm talking more prevention of a similar.
Well, I don't consider there's any particular problem to address at this point in time.
So Jersey Recovery College, if I understand correctly, was created off the back of a government strategy and piece of work. And I think if I'm getting it right, the question is more what lessons can be learned from that process going forward with things like the dementia strategy to ensure we don't set up an organisation that then fails again a few years later.
If it's specific, I'm probably not obviously able to answer your questions correctly. If we've got a dementia charity that seems to be very stable and doing good work at the moment, I think we've got other things to do other than to worry about what may or may not happen in the future. It seems quite sound to me. We're under a lot of pressure in a lot of other areas, so it's not, I have to say, perhaps I'm wrong, but it's not an area of focus for me at this point.
So you haven't identified anything that
No,
you can learn from this?
No, I haven't.
Do you want to ask one more?
Yeah, just you were going to, I think, submit a bid from Digital Jersey for assistive technology, and I just wondered whether that had been done and what stage that bid had reached in terms of being successful or not.
And I'm sorry to say I can't answer that off the top of my head, so I need to go and check. was being done jointly with Dementia Jersey, so I need to go and check what happened.
Okay, thank you. We do have some more questions on dementia, but we will send them to you because we need to save the time in the hearing. Thank you. I'd like to ask some questions about the recent announcements you made, Minister, about the restructuring of Jersey's healthcare system. Could you advise about the manner in which they were announced? Why were the plans not announced to the States Assembly and scrutiny in the first instance?
I thought I'd mentioned in the Assembly that they weren't really in a fit state to be announced, and I confirmed that once they were, then they'd be announced through the formal processes. They'd go to Council of Ministers, they'd come to you, then they go to the Assembly, then they'd be made public.
I'm interested in the process that you've gone through there. Could you talk us through the process you are going through in relation to those restructuring proposals? There must be a series of steps.
Yeah, there are a series of steps. I've been in office for 8 months. Over the course of time, I've made some observations. Those observations are built up over the course of time. They've started to build a picture. Once I got the bones of a picture as what I thought was right, I started to have discussions with my policy officer, with Ruth, and we've been, in conjunction with the assistant ministers, developing them ever since, and that's where we are at the moment. We're in further stages of development.
Is there something that can be written down and seen in a set of proposals that
It's taking shape. It's not so you don't wake up one morning and suddenly have a ready to go strategy, do you? When you're no, it'd be nice. It'd be nice if we did. It would make life a lot easier. This is an evolving process, and when you're trying to reshuffle these to make them more efficient, what you find quite quickly is that this element might not work, or this element's going to create a problem. Then you've got to deal with that. You've got to go and talk to the people that may or may not be affected by it. You've got to work out what the consequences are. And I, as you know, I've shared my views as I've gone along. When people have said to me at any point in time, "What are your current views?" I'm quite happy to sit and talk about the sort of direction of travel. As you know, I was asked to do that at a conference in the town hall, and I gave a series of observations. And at that point in time, I said, at this point, this is what it's starting to look like. I think for me, that's good open politics, isn't it?
you said in the Assembly that you were undertaking a consultation, that you are now consulting around these proposals. Can you describe what form that consultation is taking?
At the moment, it's basically talking to the senior leadership team at HSS. We started talking to GPs. We'll talk to 2 or 3 people in the larger charities to start with. As I say, it's not a formal process. This is basically ironing out the areas that we think are of concern, so that we can come up with something that when we do start a formal process, we've got something that's credible.
So what is being consulted on? Is there a written set of proposals that are being consulted on?
Yes, we've got a small set of slides that indicate the direction of travel, yes. Yeah. Okay.
And would it be possible to share those with the...
I thought we had a briefing organised.
So we do have a briefing in diaries with the Scrutiny Panel. I believe it's on the 4th of October. It might just help to understand that what we have is a very small, I think it's 3 slides, which are an initial concept. What the Minister has been doing is testing that initial concept with a very small group of key stakeholders. And once that initial concept has been tested, then we will be moving to wider consultation with other providers, with staff in the department, and obviously with Council of Ministers and informing scrutiny. And that is the reason why there is a date in the diary to come and talk to you on the 4th of October, because we are confident at that stage we will have gone through that initial concept testing.
It won't be the finished product, but it'll be hopefully fairly close. It'll be the bones of it.
How do your proposals sit with the announcement by the Assistant Chief Minister in the Assembly about cutting management posts? How will that affect health?
To be honest with you, until we've got it finalised, we won't be able to analyse that properly. But that'll be a process that we'll go through when the time comes.
Mm-hmm. And do you believe that there is scope to do so within health?
I think there has to be, really. We'll have to make a good case for it. I think that what we're planning on should actually make things a little bit more representative, a little bit more efficient over the course of time. One of the meetings recently, I said to the people we're talking to, if you're designing a health service, would you design the one that we've got now? And the answer, I think, unanimously was no. So I think that leads us to suggest that it might be time for a review.
And are there any particular roles that you've identified as the Minister at the moment that you think you would be considering for changing or?
I think the overarching difference at the moment is that what I'd like to see is somebody as a chief executive of an entire health service rather than just HCS. And their terms of reference would be to provide a sort of holistic, single, seamless, integrated health service.
So this would be a new role?
Yes.
Okay. And how could you compare how it differs from the current
Well,
structure?
as I say, we're not really quite decided as to the exact role models, whether the person at the moment that would run HCS moves up and we just have that board still reporting through to that, or to introduce an additional, not a different tier, but somebody who also works as a coordinator at that level. That's the sort of analysis that we're doing at the moment. But I think the important thing to say is that the overall difference is that we want to put a representative body or board together which reflects the composition of health in terms of public health, charitable sector, primary care and HCS, with somebody charged, and some of it may have to become statutory in order for it to be workable.
Sure, and how would the interim chief nurse fit in with that?
That's still to be decided as to whether there'd be an overall island chief nurse or we'd stick with the model we've got. These are the discussions that are happening now, and you can appreciate that they're sort of quite important issues to get right before we go public with any model.
Could you be clear about the future of the health board? We currently have an advisory board, it's up for review. What you're suggesting is, it seems to me, a new role in that, a new chief officer role, and then a newly constituted...
No, I would say without seeing, it's a shame we haven't got the slides to show, we'd have done the briefing first because we've discussed it, but no, the advisory board remains the advisory board. And at this point in time, they are an advisory board to HCS. And there's no plan to change that.
So it's a new board.
This is more like an operations board. This is basically the team level with HCS working with primary care, charitable sector and public health.
And care services?
Yeah, the whole thing. So like I say, we really want to try and have a sort of a more integrated health service.
Appreciating that it's early days and things you've explained about the process so far, could you give us a bit of insight into the evidence base that you're using to move forward from, and how the key stakeholders, the small group of stakeholders that you're going to engage with first, how they've been chosen?
Right, what are the motivations? I keep quoting the same sorts of things, but at the moment the interaction between the various parties is sometimes a bit fractured and sometimes a bit fractious. And I think we all witnessed GPs, primary care, not having an uplift in their subsidy from the state over a 10-year period, and I think that was detrimental. I think that we ended up with a situation 18 months ago where the cost of going to a GP, I think, was £70. And I think people with limited means probably would avoid going to the doctor. And if you avoid going to the doctor and you're not well and things get worse, people end up in secondary care and costing an awful lot more to put right than they would have done if they'd have gone to the doctor as they can at the moment for £10. But that issue took 10 years to resolve, and I don't think we don't want to be in a position where that happens again. Similarly, I don't mind saying, when I came to office, the idea was family nursing was going to go out to, their service was going to go out to tender in the UK to see if we could get better value. On an island of 100,000 people, that made no sense to me at all. I thought it was destabilising, and that's just a political view, and it may not be shared by everybody, but it seemed to me to be a little bit pointless, and I think we can do commissioning better.
So they're some of your stakeholders?
Those are the sort of things that led me, and I'm looking at public health, and I'm going to say I've only been in post 8 months, but I'm led to believe that public health sort of does tend to shrink and grow at various times, and it hasn't really got a stable role in things, and I'd like that to be stabilised. I'd like their budget to be, I'd like to see what they do to be recognised and continuous and stable, and those are the sort of things I'm trying to achieve.
Okay. So there's no kind of formal evidence-based data that you're using to move on from. It's kind of listening, learning, talking to people.
As a lay person, and I'm afraid I'm a lay person, I can only go with what I see. And
Yeah.
as a politician, that's what I think you're supposed to do, isn't it? Look and recognise what you're dealing with and do your best to put the bits together and try and take as much guidance as you can from the people. That
With
know
the
this-
support of your
know-
officers who
know their
have
specialist areas.
lots of
Absolutely. Yeah.
data.
And we have discussed this with the officers, and like I say, I've made it very, very plain to people, nothing is cast in tablets of stone. So if anybody's got any concerns, they can put their ideas in.
What's been the advice from your officers about all of these ideas that you have?
I think in principle, I think the principle is welcome. A number of people have pointed and said, you've got this to think about, you've got that to think about, and that's the whole purpose of going to the people at the most senior level at this point in time, because they're the ones that have got the sort of the longest perspective on things.
And what's been raised? You said those things to think of. What can you give us some examples?
For example, taking somebody to run the whole issue starts to create potential problems in HSS about people's grades and levels, and that could be a complication. So we have to find a way around that, because we don't want to demote anybody, and we don't want to offend anybody. That would be very, very counterproductive at the beginning of a process. So those are the awkward things that we're wrestling with.
Can I just confirm, you said that you were listening to these consultation opinions and so on. If there was a strong view expressed that a significant part of that proposal that you'd come up with needed to change, you would be prepared to change it?
Yeah, I think we've already got. I think it's safe to say that we've already. I think we modify something virtually every time we talk to somebody.
We have developed an initial concept. That concept is based on evidence. From a policy perspective, we've looked at other jurisdictions and what models of good and effective change look like in other jurisdictions. So we've looked at what a proposed new structure for the system looks like. We've put that on a piece of paper. We've tested that with a very small group of people. So executive leaders of the department and the 5 GPs who make up with the primary care board. It has not gone beyond that at the moment. They have given us feedback. We have made some significant changes to the model based on that feedback. And once we have gone through that initial concept testing, we will be rolling out to a wider consultation. And as ever, we do listen to what people say and reflect that back.
We've also spoken to public health at some length as well.
So the executive leadership teams of the teams that Tom is responsible for, so health, public health and de facto health policy.
So that will be a formal consultation?
There will be a formal consultation, yes. At the moment, we're testing a concept before moving to formal consultation.
As quickly as we can, because Ruth's under a lot of pressure, as you probably know, because we'd like to get this done, if we can, and implemented within this parliamentary period.
And Minister, you mentioned things being perhaps delicate and having a sensitivity around that, and I wanted to ask you about the cultural issues and governance challenges. How are you managing those and ensuring that there's improvement and change there whilst this restructuring is happening?
On the day-to-day side of things, I'm comfortable that those issues are being in the process of being dealt with. Some of them are quite long-standing, and I think they'll take quite a long time to move, but they are moving in the right direction. And I sometimes think when you bring about structural organisational change, that's a good stimulus. It's a good point at which you can get some of those things to come together. Because as I say, you're sort of moving the furniture around a little bit. I think it just makes people feel that they can move in a different direction. So, yeah.
And do you have any experts in this area advising you, aside from your officers, of course, and the additional experts?
No, I'm comfortable that we've got a good collection of people. We've been lucky. We've now got a new deputy medical director, who's, I don't mind saying, proving very effective as well. So it's a very, very good addition to an already good team. Yeah, yes.
Can I just say, I think the advisory board are also very helpful, and we are listening to what they say as well.
And we've got actually a session booked with them for tomorrow, I think. We've got a team session with them tomorrow to go through the details. So we're being quite thorough, and I think you can appreciate that there's a need to be thorough before we start going and sort of standing on a mountaintop, sort of broadcasting what we're doing. It's a pretty serious set of changes if they happen. So
I think I have in mind the reforms in the UK, which Chris will be very familiar with, in 2012, the Lansley reforms, which are still being quoted only earlier this month, as a disastrous example of health service reorganisation.
Nice of you
So
to
the
choose
potential-
something negative.
So the potential, the potential for politically inspired reforms to go wrong is certainly there. So I'm sure Chris has seen the effects of that. So I think it feels appropriate that this should be subjected to pretty searching analysis.
Yeah, that's why we're taking our time. It's a great shame you couldn't have picked a successful alternative to bring up, but there you go. Such is
We
life.
wish you success, of course.
Thank you.
Minister. In terms of the costs in the short term, my understanding is that you're hoping to achieve savings in the long term with this restructuring. Am I correct?
I don't think we go as far as to say that it's. What I am hopeful is in the long term it will help. It will help with efficiency. The extent to which those efficiencies can deliver savings is yet to be seen. But you would hope that it might. What you really want, even if you don't get savings, is you'd like to think that it would eventually deliver perhaps a yet more effective service than we have at the moment.
So,
it's a combination of goals. If
Sure.
you can make it cheaper and more efficient, fine. But if nothing else, if it just helps to speed things up, reduce waiting lists, make things more efficient and more balanced, so we don't get these imbalances that we've seen in the past that I think have been quite dangerous and quite damaging.
Yeah, thank you for outlining your vision to us for the long term. But in the short term, what will the costs be of implementing this restructure?
To be fair, I don't think we've identified anything particularly at this point in time. We're doing all of this within the resources. Sometimes people stay late after work to have discussions with us, as to speak, put in a lot of overtime. So we're actually trying to do it within the resources that we've got. Once we've got a final model, we can look at it and say, well, this may be plus or minus, but...
Yeah, are you able to advise if there will be a cost?
So where we are at this point in the process, we haven't done a full costing because we don't have a settled proposal against which to cost. But obviously, we will do a full costing at the point at which we've got a settled proposal that we wish to go out to consultation on. As things stand at the moment, the additional costs associated with the concept we have at the moment, which might not be the one that goes forward, they are relatively minimal. So those costs would arise with regard to some changes to a very small number, or some potential changes to a very small number of senior roles. There will be some additionality within that, some additional roles. And also, as Tom has said, one of the things that the concept hinges on at the moment is the development of a partnership board so that other partners have a say in decision making around healthcare strategy and the services that are required. And there is a recognition that those partners would need to be remunerated for their contribution. So there will be a cost associated with that as well. But at the point at which we have a firm concept that we wish to roll out, we will also have the costs alongside that as well.
Thank you. Does someone want to ask a final question in that section? No, okay. Assistant Minister, I believe you were trying to say something earlier. Would you like to
No, I
speak?
think we were just also trying to make the health care on the island seamless, so that there's better communication between primary care and secondary care, and everybody's working together.
Okay, great, thank you.
One final point is I think we need to step up our efforts in the digital area. I think we need more money because I think everything, the more I look at it, the more important it seems to me that everything's interconnected. So we will be looking for more money for digital work.
Yes, we might come back to that. Thank you. Related is the Health Board announcement that you have appointed a new member of the Health Board. Could you explain why that appointment has taken place when previously you expressed that the board was perhaps not necessary?
No, that's not correct. I seem to remember making the point at the time when the board was first mooted that it was early days to be putting a board in place, but since its implementation, I haven't said that it's unnecessary. I found it very useful, to be honest with you. I think because the finances had found themselves in a bit of a muddle, some significant amount of work is being done to make sure we have clarity on the finances. It made sense to appoint somebody who was more specialised in finance on that board. So that was the reason for the place existed. That we were supposed to have somebody that's centred on finance, so we thought we'd go ahead and.
I guess I have in mind that in April, I think it was, you said when the chair of the board left that you wouldn't appoint a replacement because there wasn't time, because the future of the board was going to be replaced, and that person still hasn't been replaced.
It's the chair.
But you feel that there is a time to replace the members of the board.
I think the job of the chair is perhaps slightly different. It's more onerous, more time consuming, and more of a commitment. So it seemed to make sense to do that.
So you still have no intention to appoint a chair?
Well, I think the review comes up fairly soon on the board, and at that point in time, probably will.
So Minister, you've said that you do value the board. Are you engaging with them, and how is that engagement happening?
Well, we engage with them as much as we can. You've got to bear in mind that in an ideal scenario, they wouldn't, at this point in time, because we're not in a position of turbulence, but there's an awful lot going on at HSS. And I think if things were, in the longer term, things were more settled, they'd probably have less involvement. But there's, at the moment, there's quite a lot of day-to-day comings and goings with the board, which they're probably finding unexpected. I don't think they find Jersey as a typical board situation for them.
Can you give an example?
Well, I think Jersey is quite different to the UK, and it's 100,000 people. People get more involved. I think most members of the public have sort of direct contact, and I don't think they're sort of used to the extent and level of involvement that they've found themselves in. So hopefully that's going to stabilise over the course of time. But coming back to your question, we have periodic phone calls, occasional Teams meetings, and meetings away from the board when they come over.
Can you give an example of something that the board has advised that you have actioned recently?
If they'd asked me before, off the top of my head, trying to think it through, probably not. But I can tell you there have been a number of different things where they've either phoned me and said, "What about this?" or I've phoned them and asked for a bit of advice on a number of things. So, without quoting off the top of my head, there have been a number of times when I've been very pleased to be able to reference them.
Would the officers recall any of those instances?
Not off the top of my head, but I can certainly provide you some information, and I think if it would be useful, as you know, it was always intended that there would be a review of the board ahead of a States Assembly decision as to whether or not they should continue. The States will be making that decision in April-May time next year, and one of the things that we are working for now is the board evaluation process in order to be able to demonstrate value to the States Assembly to inform their decision making, and we can certainly that's being worked up at the moment, and when it is ready we can certainly share that with the panel.
Thank you. Any more questions on the board?
I just wondered, given that we've got Chris here, if you'd like to speak
Yes.
to Chris about the usefulness of the board, it may be that you'll find there's some useful
About the usefulness of the HCS
of the board, yeah.
Briefly, if you can, I'm just noting the time.
Yeah. Well, I suppose briefly, I think it's essential. It's an essential mechanism for holding the organisation to account. It also enables us to bring skills into the debate that otherwise we probably wouldn't be able to attract, which would be typical of a benefit that you'd see in NHS boards. But I think the fact that it holds people to account, that we hold our meetings in public, has given some great benefit to that and provides a discipline of accountability that wouldn't otherwise be there.
Could I just add that we really appreciate the expertise of the advisory board, and we're extremely lucky to have them. We have to thank them very much.
Thank you. I'm sure they will be pleased to hear that from you, ministers. Thank you. So we are going to move on to some questions around the proposed budget now. Minister, please could you talk us through how the budget allocations for the various expenditure and service levels within HCS were determined by yourself and your team?
To be honest with you, I'd like to hand because
If you could start with an overview and then sure we can hand over.
I have to say, the finances are complex. There's still some degree of uncertainty about certain elements of them, and I've just taken the advice that I've taken from the team. That's Obi, as you know, the turnaround manager, and the remainder of the team. So I haven't been involved in intimate breakdowns of those budgets. I haven't, to be quite honest with you.
So in terms of your political vision, which you've outlined your long-term political vision, that's becoming clearer. What do you see as the main priorities for HCS and that are within the budget?
In terms of the functions,
Which bits do you feel like are the priority? You know, your vision needs funding. You've put in for extra funding. To what extent are you matching the vision to the funding?
The extra funding, and as I say, I'll draw on the professionals for this, but the extra funding is to actually fund the work that's being done or that's been committed to beforehand. There's no extra. There's nothing extra that's going to be put into place this year or next with the budget that we've got. And the budget that we've actually asked for will barely cover the expenditure that we've got, because we're still finding expenditures that were not accounted for, or some accounting processes that weren't perhaps as sharp as they should have been, which are putting us under pressure. So there's what I was from my point of view, what I was hoping we were going to do, and I think I'm fairly comfortable that we've done, is provide a baseline where, instead of coming back for lots of money every year, we actually understand what it needs to run in 24 and 25, and that becomes our baseline funding going forward, bearing in mind that health inflation is constantly outstripping standard inflation, and we've got the added difficulty of coping with initiatives that come in. Not that they're wrong, but IVF funding brings in another requirement to suddenly find another $750,000. Assisted dying brings in another in another layer of expense, as do expensive drugs, as Kaftria, I think, is one. I think it's £120,000 a person. There are now going to be 3 people. That's another £350,000. So you've got all of those additional stresses on top of the fact that health inflation generally is running in advance of ordinary inflation.
When you say health inflation, do you mean the fact that there's more need amongst them?
Yeah, it's a number of different factors, not least of which is the cost of drugs are going up beyond the cost of inflation. I'm sure Chris can come in on this. The cost of care in the UK, health services are in short supply, and people providing health services are in a position to put their rates up. And I think it would be useful to hand over to Chris, because he's got a little bit more intimate knowledge, but I think some costs have gone up between 20 and 40%. These are very, very difficult to cope with. So, as I say, if we can establish a base budget and we can articulate what's happening over and above that, we can then come to the Assembly and say, this is the reality of the situation. So I'm not looking to shuffle around the work that's being done. I think is fine. Those are the areas of work that we'll carry on doing. What I'm trying to do is get stability into the situation, and a point where we know what we're doing with the finances and what's going to be required in the future, because we may have to look at different funding models over the course of time.
We're literally having to pay for all this wonderful staff who are doing their jobs to look after the patients and all that goes with it, physically and also physical health and mental health.
And we've got an ageing population, and the balance between working and non-working people. We're going to have a higher incidence of dementia. These are all things that are going to play havoc with having a stable, balanced budget. So in answer to your original question, I wasn't trying to be facetious. I don't get involved in trying to chop things around or having pets to move things in different directions. I accept that the work that we're doing is good, and what's currently being delivered is going to be delivered. If we can sharpen up on any of those things, fine, but we're really trying to find balance and clarity going forward. It is worth, I think, handing over to Chris to articulate some of those things.
I'll be very interested in hearing, Chris, some of those details, but just at the political level, in a way, you're the big winner in the budget. You've got a lot more money than anybody else.
Yes.
The baseline that you keep talking about, the extra funding you requested crept up during the year.
Yeah.
Are you confident that you now have that baseline, and that when you come back to the Assembly, it will be for those incremental increases due to inflation and demand, not that there's some big black hole?
No. I think any black holes, 95% of them will be found. And I have to say, since I stood up in the Assembly and made that statement, Obi has come back with another couple of problems that he's found. Okay, because this whole time he's dredging through every area of the finances. However, what he has said and what we're going to endeavour to do is to make sure that even those anomalies are dealt with within the budget that we've asked for. That's going to take a lot of fine tuning. Believe me, there's an awful lot of work going on to cut corners everywhere we can. So the intention is to try and stabilise that at the money that's been asked for. Because, as you say, people run out of tolerance. And when you say we have been the beneficiaries in this budget, this is true. But I like to think it's the island that's been the beneficiary of that because the health services for everybody.
I'd like to understand how this would look for service delivery. What will the public see? So you mentioned that the bids that are currently in, if they're approved by the Assembly, will still only barely cover the expenses of your department. What does that look like in terms of service delivery and quality of service?
Well, you've got a team of people that are. We've had the turnaround team now for quite some time. That's been embedded, and some of those changes are going to, over the course of time, hopefully result in things being a little bit clearer and a little bit more efficient. So hopefully over the course of time, waiting lists will come down and the service will become more efficient because of the constant effort that's been made by the senior team and all the people that work with them.
But there have perhaps been on occasions in the past when money was taken for the HIF, but it wasn't actually used to pay for what they said it was going to be paid for. It's paid for salaries, for example. So there has been a great deal of work for Obi to try to work it out, and I think a lot of it had gone back centrally, the finances, and it's been really hard to unpick.
Yeah, and Minister, would you like Christopher to add some?
I think Chris could add some useful comments here.
Shall I just, and Mark can give you some of the numbers because he's got them in front of him, but I think if you look at 2025, so the government plan for 2025, as you say, we are looking at a situation where those costs or that budget will cover the existing service. The only additional funding we have actually is for IVF. So the process there was no government planning process as such in the past. I think you, Chair, you sort of alluded to the submission of business cases. That process didn't exist this year for next. So the funding that we've got, which covers pay increases, some inflation and various other things, and Mark can talk about what those numbers are, but this will only enable us to continue to deliver what we're delivering this year, so no great change next. This year, we were looking to deliver a deficit of some £24 million. In month 7, the month 7 results, we felt that there was a risk to that, and if we didn't put in place further mitigating saving actions, we could be at 29 million. And this is largely due to, and the Minister's alluded to this as well, seeing some increase in drugs, but also packages of care, where it is exceeding even our pessimistic forecasts. So we're looking this year to maintain a deficit of 24 million. We are looking, in addition to the original financial recovery plan of some 8 million, I think that's right, isn't it, Mark? We're looking for another 5 million, so we can keep at that 24 million. So we're not going to see significant change. As was mentioned about management costs, we've actually included in the 2025 plan a reduction of just over £500,000 in management costs. We agreed that as a senior leadership team recently. But as regards to service change and development, all developments will have to be done within the existing resources that we have. I think, again, the Minister mentioned that, and Obi, Hassan and I have often said that, of course, the financial recovery plan and efficiencies alone will not be sufficient to close the ever-increasing gap between the costs of healthcare. I was going to say in Jersey, but across the world, it's a global challenge, isn't it? And there will have to be, in my view, a conversation and debate, a political one, about how healthcare is funded in Jersey over the coming years. And it's a debate, obviously, that the UK and other jurisdictions are having as well. But it is whilst we can continue to make savings, that there will be a limit to that. The financial recovery plan is delivering. Actually, we're expecting to over-deliver this year on our financial recovery plan savings. But as I say, the costs that we're seeing, which are not uncommon across other jurisdictions, are causing significant pressures. I don't know, Mark, if you want to add to that.
Can I just say thank you? That was really interesting and helpful, and I will pick up on in a minute. What I'd like to understand, so the 24 million deficit that was just quoted, and perhaps Mark actually might be the person to help me understand this. It was my understanding that the budget had to be balanced. So how is it that there can be a deficit within the public finances law?
You're correct in terms of the public finances law does state that government departments have to manage within their allocated budget. It is a fact within the government that within year it is possible to allocate from central reserves or move allocations between heads of expenditure. And those discussions are ongoing with Treasury around how the 24 million deficit will be managed within the year. In terms of the 2025 allocation, just to give some context, the 2025 budget allocation for the department is set at 322 million per the government plan, which includes an allocation of deficit funding of just under £30 million. That is actually less than we're projecting to spend this year. So the deficit position this year of 24 million is a spend of 329 million. So we start 2025 with a lower budget than the actual outturn for 2024. 2024's was a similar situation in that the government plan had already allocated the 2024 budget. So the decision-making processes over the course of 2023, yet we had to rely on an allocation from central reserves to balance the health budget in 2023 as well.
Okay, thank you. And Minister, I see you nodding when talking about sustainable health funding. It mustn't be an easy solution, must it? But do you see any solutions on the horizon for this deficit in terms of how we fund our health system?
No, I think we've got to, as I say, we're going through a period of stabilisation at the moment and gaining more clarity, and I'm sure that probably 6 months from now we should have total clarity and know exactly where we are, so that everything that goes forward can be analysed and assessed. Hopefully we can then start to predict more accurately from our new baseline, and as that when we can have a proper trajectory from then on, we'll need to start talking about ways to fund that. One area that may be of interest is illness prevention, and I think that's an area that we need to focus on. I think a lot of places, when I look at the news and read articles, people are saying that we should invest more in upfront healthcare. I think when we look at comparisons, I think Jersey's particularly bad at it. I think we spend more on secondary care here than primary and preventative work than other places, and I think we need to find a way. Not quite sure yet how we're going to do it, but I think we need to change that balance, which is going to need more upfront funding over a period of time, so that we can actually start to invest in preventative measures.
And is that something that the current Council of Ministers will be able to make significant headway with in this term, do you think?
That's something that's under discussion. The problem has been recognised, or the solution has been recognised. I think the need for this is common everywhere. Everybody's in health seems to be having the same discussion about trying to get in front of the job rather than tail behind it. But it does require an upfront injection of money in addition to what you need to keep the ship afloat while you're doing it. And I think that's why those things the can has been kicked down the road, as it were, because nobody's really come up with a chunk of money to start doing the job properly. But the worry about not doing that is if you leave everything until the last minute, then the costs of dealing with it
Where do you
increase.
think that extra funding should come from? Would it be savings from other departments, or do we need to raise more?
A few ideas, but I don't think this is the time to sort of
Give us
make them public. Well, there are not many sources of income, are there? That's it. Increased taxation, savings that we may have, borrowing. That's three. I think we might be in receipt of some for the two money as well, but I'm sure that's been. already penciled in for other purposes. So, yeah, there's no easy way around this, and that's the decision that we've got to take, and that's the decision that hopefully will come back to the Assembly in the not too distant future. To make that decision, do we want to put some money up front? If we do, where are we going to get it from? And do people think that's a good way to be spending our money? On a personal level, I think that's where we should be.
Can I just clarify on the deficit question? Is it the case that we've been running deficits and bailing them out from the central reserves, central consolidated fund basically, but the new budget for next year incorporates those deficits so that in future there will not be a call on those transfers because we have rebased the budget to include that level of funding? Is that the current situation in the budget that you have that has been proposed?
So from Treasury's perspective, I mean, an assumption that 2020, that the current deficit will not further increase, is included in that piece of work. So identifying that in 2023 and 2024 the department's been underfunded. What isn't built into this, other than allocation for maintaining healthcare standards funding of 2% and non-pay inflation, those are really the only year-on-year growth items within this. So I think there is an element of uncertainty around some of the cost pressures on the department, such as in the social care sector, where people's needs are assessed and health are required to fund any element of people's long-term care that is over and above the benefit funded level. That is a pressure that falls on the department that is not fully controllable, and the department would have to meet the needs as they are assessed for an individual. So there are elements of expenditure falling on the department that I don't think we could say with any degree of certainty that there will not be further budget pressures in future years. So from Treasury's perspective, this has brought the funding to a realistic level based on what we've seen in 23 and 24, but it's not totally future-proofed around any further pressures there may be.
Could I go one step further and say I think we can guarantee that it isn't future-proofed? And I think the point to make here is that we're hoping we've got it stable for 24 and 25, and that's the right sum of money. But during the course of that time, what we're going to have to try and do is look further down the line and make a real estimate on where we need to go for the next 5 and 10 years. And some of those figures might look quite disturbing. But I think the sooner we can come up with those figures and make them plain, rather than hiding away and then coming up at the end of every year and saying we need another chunk of money, I think we need to be on the front foot going forward and saying, well, for 26, 27, if we want to do X, Y, and Z, these are the realities and these are the reasons for those realities.
Would you say this is an urgent priority for you?
It is, absolutely. And there's a lot of work that's been done. The whole team have been working hard on this for quite some time. They continue to, and we're going to keep the team together for at least another sort of 6 to 9 months if all goes well. That's what we're looking to try and do to make sure that we get right to the bottom of this.
Is that level of urgency and the understanding of the problem, is that shared amongst the Council of Ministers?
To the extent that they've all got their own work to do, but we do update periodically, and yes, I think that's known.
It's just unfortunately the environment needs money for climate change, and every department, infrastructure needs it for the drains. Rightly said, we're viewed as the lucky recipients of extra money. We're the lucky ones, but they don't. They're envious.
Just to examine some of it. Sorry, carry on, Philip.
I was going to say, listening to your officials, Minister, I do get the impression that what the HCS is doing is essentially firefighting, trying to balance the books against enormous pressures. And what also always comes back to my mind is the comment of Chris Bowen, which he's made on more than one occasion, which is that if we go on in the way in which we're going, the whole of the state's budget will ultimately be consumed by health. And that is clearly a completely unacceptable and
terrifying.
And a situation which cannot be allowed to
absolutely right
to emerge. But who is doing the thinking about the strategic stance that the island ought to be taking to limit the amount of expenditure on health within the demands of the system?
It's
Who is doing the
interesting
strategic thinking, Minister? Is anybody doing
I
strategic thinking?
I'd like to think that we're all doing that strategic thinking. It's an ongoing situation. The reorganisation of the structure itself is part and parcel of that work. The truth of the matter is, people want better and better services. Science delivers better treatment for people all the time. That treatment is expensive. We're facing a demographic challenge here where more and more people are falling into the older age bracket. As you say, dementia is going to increase simply because there are going to be more older people getting dementia. These are all of the realities that have to be put into the pot and analysed, and then we have to make a decision as an island as to how we're going to cope with them. Are we going to have to raise taxes? Are we going to have a health tax? These are all the questions that have to be asked, and we have to face up to them. But all I'm saying is, what I am comfortable is that an awful lot of work has been done by the team to sort the finances out, because there was a lot of, from the stuff that's been explained to me, there was quite a lot of confusion about where money was and where money wasn't. I think that running into the new year, we're going to get a fully clear picture, and from that point onwards, we can have clarity about where we're going. We can make better estimates of what's required, be open about them, and bring them forward for discussion. When you talk about strategic development, I think one of the things that we need to do, as I said before, was health prevention. I spoke to our cardiologist here, and he was explaining to me that if you can stop people having a stroke, you save the exchequer between £250,000 and £500,000. The same with heart attacks. These things, when they happen, they're extremely expensive. If somebody has a stroke and they live for another 20 years, that's very, very miserable for them, and it's very expensive. Somebody can have a pacemaker fitted and avoid having a stroke, then I think your money is well spent. But you've got to have that money up front, so you've got to be able to monitor people, so you pick up the problems in the first place. So strategically, yes, I think we need to put a lot of focus on prevention, because that's the only thing that's going to reduce the rate of increase as we go forward. So that's quite a bold move, and that's going to require quite a lot of money.
Wasn't there supposed to be a political group working at a strategic level to look at that big question stuff? And then it was supported by an officer group. Is that mine?
Help.
Ruth's nodding.
Yes, there was.
Rescue me, Ruth.
So there was a political group. It was called the Health Funding Reform Group, and that was within the previous government. And we did some work around understanding the funding, not in HCS, across our healthcare system. So what we were spending money on, what we weren't spending money on, and looking at how that differs to other jurisdictions. So that's how, as the Minister has just said, we know that we're quite unique in Jersey, and that we spend a lot more on secondary care as a proportion of our total budget than we do on primary or prevention. We also, part of that work was we cast forward future healthcare spending. So we said, if we continue as we are at the moment and don't create efficiencies, what does this look like in 20 years' time? And what it looked like in 20 years' time is a very significant gap between expenditure and income. A gap that is of the extent that whilst efficiencies and improvements are very important, they will never close the gap. So in terms of taking that work forward, it is difficult and complex work to take forward, partly because it's got a really horrible sticky question in the middle of it, which is, if you strip away everything else, it's either we do less or people pay more. And one of the pieces of thinking that the Minister is looking at with setting up the partnership board, one of the aims and purposes of that is to have providers having ownership of some of the solutions around that sticky question, rather than it just being political. Because you need longevity of solution and longevity of thinking to bring forward the solution to the challenge that we have, rather than it just falling off or changing with political winds. So the approach that the Minister, who is very aware of these particular issues, has is let us create a appropriate structure to jointly come together to determine what the options for change look like and to own those options for change into the future.
But just for clarity, the political side of that at the beginning of it is now just with the Health Minister?
No, so the group still exists, but it hasn't met for a period of time because we've been doing the work on the structure to then take back to that group and to join those pieces of work up.
Okay.
Worth mentioning that I'm part of a team of there's 3 assistant health ministers with me, so we've got sort of a fairly large dedicated political group already. So, and that works when we have weekly meetings, apart from the meetings where we come together during the course of the week as well. So we try and keep the thing as well threaded as we can.
And can I say, I think we're trying to encourage also islanders to take responsibility for their own health and to live healthy lives if they can, with a good life-work balance and eating well and sleeping well and exercising and ideally not smoking or vaping or taking illicit drugs and keeping alcohol consumption as low as they can. So we need to encourage all of that too, because that's all part of the picture, because that's all part of the prevention.
There's quite a lot of work we're going
There's
on
a lot, there's
in
lots.
public health actually that are
Yes.
focused on trying to make early changes to get things in the right direction from early days.
Can I ask where the health strategy sits in this work? Because it would have seemed to me that a strategy that set out, for example, how much care we want to do in the community, how much we want to buy abroad, what our overall health ambitions are, that might be a useful thing to inform this work.
Perhaps it's slightly unorthodox, but the way we've been running to date is to identify problems, bring the threads together and try and get on and make the changes as we go. So in an ideal world, you get all your stuff together, you put a strategy together, but I do worry about grand strategies, so that by the time you've finished putting the strategy together, there's an election, you move on and the whole process starts again. So what we've tried to do, forgive me for being a bit basic, but we've sort of short-circuited things. We're actually working together as closely as we can and bringing about those changes, formulating ideas, trying to take them forward. I appreciate what you're saying about a strategy, and you know it's always there, waiting to be addressed. But there are so many real day-to-day issues to get right. I made the point the other day about before you put the deck chairs, move them around on the deck, you want to make sure that the base of the boat is watertight and fit for purpose, and that's where we are at the moment. So I'm not being glib about health strategy, but I think you can see there's an awful lot of work going on, an awful lot of good, dedicated people bringing threads together. So
I guess the missing point in that is, or the missing part in that is public involvement, and the Assistant Minister referenced that. The point about a strategy is it engages the whole island, or could potentially engage the whole island in the debate, and that's the missing piece.
Wouldn't argue it is, but I don't think we're quite ready for that. And for reasons that I've said, you need to get your finances have to be absolutely in order, your structure has to be clear and clean, you have to have a completely settled situation, and that's the point at which you can go forward and say, well, it's already want to decide where you want to go, but if you haven't got the vehicle to get you there, it's a bit of a pointless exercise. So to my mind, while you're putting the vehicle together, you start mapping out a sense of direction and you move forward. So it's a sort of integrated process that takes place over time. I hope that makes some sense, because I'm not being glib about strategy, but I think there's a time and a place for it, and that's probably not quite yet.
I want to touch on the detail that you've given about different partners being involved and making sure that people are involved in health are there from the beginning. How are you also ensuring that there is innovation and creative thinking and new ideas from people who maybe have never been involved in health before?
I don't mind saying there are two sources of that. One is our board. We bring in a lot of external expertise, and I think Chris comes with a background, as do members of the leadership team. So I think we've got a number of inputs from a number of different places. So some of those new ideas, some of that new thinking continues to feed in.
And politically, I'm going to throw a bit of a curveball at you here.
Oh dear.
Which could be a solution, I feel, and I'd like to understand your views on it. In terms of healthier lifestyles, and also islanders being able to care for each other and address some of that social care need, what's your opinion on moving to a 4-day work week, perhaps in the public sector as a trial, and then promoting it for private businesses, which would allow islanders more time to exercise, prepare healthy food and care for each other?
There's a big economic, there's a social element to that, and there's an economic one. And if it can be, for goodness sake, if it can be done without damaging the economy, fine. But what you wouldn't want to do is to implement that. Everybody's feeling fine and your tax revenue goes down by 20%.
Well, the research shows that productivity either is maintained or increased, as well as well-being.
Not something that, I mean, it is a bit of a curveball, if you don't mind me saying, and being asked to answer that on the balls of my feet is quite difficult. But in principle, it's something that, you know, you don't dismiss things without looking at them. So if you want to have a chat about that off record, I'm very happy to talk about it. I'd be delighted with a 4-day week. And if my productivity would increase as a result, I'd be really happy. I don't know how I'd do that, but there's
The only thing for HCS, they unfortunately have to work 7 days a week, 24 hours a day.
Yeah.
Isn't that right, Chris?
Yeah.
Just to wrap up, can I check that the panel, does anyone want to put one more question in? Go ahead.
Yeah. There are some reductions in full-time equivalent staff in the budget, 5, I think. What is the rationale behind that, and
That's something I don't, Chris is more involved with that.
So is that the reduction in management costs?
Full-time
Just says FTE reduction of 5.
Yeah, I think it is, Chris,
Mark, is that right? Is that
It is,
right?
it's the 5 management posts,
Yeah.
So what was the thinking behind that?
It's a requirement, I think, was it not?
The thinking behind that is that we felt that, well, we're always looking for cost savings. We felt that we could do a bit of restructuring, prioritise things a little bit better. And as a consequence of some restructuring, we've managed to find, I think it's £526,000 worth of savings, some of which will realise this year, but some will, that's a full year saving, some will be next. So it was literally looking at our structures and seeing where we could trim things. Now, of course, when you trim things, it means you have to, you know, these people are not sat here, they're doing nothing. There are things that we perhaps have to slow down or reprioritise, but I think it was a commitment that I gave as well to the rest of the government departments, of course, who have to also reduce their management costs, as we're seeing across the civil service, that it was only right and proper that in health we did the same. So that's why we scrutinise those posts, and Andy Weir and his colleagues have been in lots of discussions about that over the weeks, and that's where we got to. We were able to take out five posts.
Thank you. Minister, anyone else want to? No? Okay. To wrap up this section on the budget, I'd like you just to outline, in terms of the health funding, what's your biggest fear and what's your biggest hope for health funding?
Well, my biggest fear is that the need for extra money won't be addressed. And I'm hopeful that it will. As I say, we've got a lot of work to do. We've got about 18 months of active time left in this government. So that's my biggest fear. What's my biggest hope is that we sort of take a bit of a leap of faith and decide to put some more money into prevention, illness prevention, because I do think that if we don't address that problem, that we're going to be in serious trouble. So that would be the two things, I think.
Thank you, and thank you, officers, for the contributions in that area as well. We're going to move on now to women's health, and I'd like to ask a general question about the Women's Health Political Advisory Board. What role has this board had in discussions about prioritisation, resourcing and funding allocations in relation to all of the women's health work streams?
So we meet every few months, and we all get together. I think you were both on the previous advisory board, weren't you?
We were, and we stepped down from that so
I
that
know,
it wouldn't
and I would
conflict with
have-
our
I'd have
scrutiny roles.
been very happy if you carried on being on it. So it's just carrying on, I think, as it always did. And it's great because it's across the Assembly board. So sort of very different, different viewpoints, but everybody's viewpoints very much taken into consideration.
And when did the panel last meet? Sorry, the board. When did the board last meet?
Just before.
It was either, I think it was July. I think it was the 19th of July, if I remember rightly off the top of my head, but I would need to confirm that date absolutely
And
for you.
we've got the next meeting next week on the 25th.
Okay. And can you advise who the membership of the board is?
Yeah, the membership is Deputy Miles, Deputy Kovacs has just come on, Deputy Barbara Ward, Deputy Elaine Miller, Deputy Lindsay Feltham, who else are the other ones?
Karen Stone.
Yes, Constable Stone
Yeah.
and myself.
And does that board advises you, is that correct? And can that board
Well-
make decisions?
We all work together and together we come to a consensus
Okay.
of what we're going to take forward.
So you take your decisions in the area of women's health based
From
upon a
what they-
consensus of that group?
Correct.
And is that the case for every political or ministerial decision that you would make in
For
this
me,
area?
yes.
Okay. Can you give an example?
Well, the example that we've been through, we discussed period products, we've discussed termination of pregnancy, we've discussed IVF. So anything that comes, I would always ask
Okay.
the rest of the panel for their viewpoint.
Okay,
And can they come back, if they don't agree with anything, or to come back, and then we, I'd go back to them.
So just to pick up on one of those examples, the termination of pregnancy. So was there a consensus amongst the health
There
board
was.
on the direction of travel?
There was. I mean, it would ideally, we would all have liked to have carried on, and we're committed to amending the termination of pregnancy law, but unfortunately, it was a consensus view that we would not be able to take it through start until the end of 2025, beginning of 2026.
Do you mind me, I don't want to interrupt your conversation, but it might be helpful for Ruth to put some context around the reasoning for that.
Yes, so just with regard to the advisory groups, oversight of the termination of pregnancy law. So the way in which we work with the advisory group is when we first started to develop proposals to take the law forward, we shared the consultation document with that group. We asked their advice on that consultation document. We then went back to the group and we asked them about how they thought we should take it through the Assembly, whether or not an in-principle debate was needed, whether or not we could move straight to a debate on legislation. So the Assistant Minister seeks that advice from the group. When it became apparent that we weren't going to be able to take the termination of pregnancy work forward in the original envisaged timeframe because of the resource constraints, the Assistant Minister went back to the group, explained the situation, said we're not going to be able to take it forward, but do you think that we should take forward what the particular high risk area within that law was, which was about non-ordinarily resident women not being able to access terminations? And that group agreed that whilst it was not desirable not to take all of it forward, if one thing needed to be done to manage risk, that was the thing that needed to be done.
That's really helpful, thank
Yeah.
you. So the decision had already been taken to not continue with the wider piece of work before it was discussed by the board.
It was
Well, it was only because we unfortunately lost resource, because we know how important it is, because we want to develop an up-to-date law that reflects current societal values and meets the needs of women. But unfortunately, we just simply do not have the resource to do that.
What resource do you need?
Okay.
Ruth might be able to elaborate on the resources and the shortage of resources, not just financial.
Okay, so the challenge we have is, and unfortunately the axe just falls this way sometimes. So we had a dedicated member of staff who was working on women's health. That dedicated member of staff got a new job. The post was vacant. The Council of Ministers made some decisions around savings targets, which meant that we were in a place where we could not replace that vacant post. So we had no officer dedicated to taking forward this piece of work. So it was not in any way a conscious decision that we wouldn't continue this work. It was just driven by the particular circumstances. So the post is still vacant. So in order to take the work forward, the termination of pregnancy work, if we were to start working on it again immediately, rather than having pushed any development on it forward by a year, which is where we are at the moment in terms of the resourcing, we would need replacement policy resource. Replacement policy resource comes really in one of two ways. It comes in the form of a policy officer, or it comes in the form of consultancy support. Policy officer support is, I always believe, not only is it cheaper, but it's actually better because you embed people in your team and you leave legacy and learning. The challenge that we have, even if we had the money to recruit a new policy officer, is actually our ability to source an experienced, competent policy officer. Policy is in order to be a good policy officer, you have to learn your trade, and that takes a period of time. And in the Government of Jersey, because we are a small jurisdiction, we often struggle with getting specialist skills, and policy is one of the areas in which we struggle. That is the reason why SPPP has an apprenticeship scheme for policy officers, and that apprenticeship scheme is working well. But it still takes a number of years to take someone who doesn't know how to work within the policy arena to become a competent policy officer. So we've got a money issue and we've got a resource capability issue around that particular piece of work. The other key piece of resource that we would need to be able to take this work forward in a timely fashion is law drafting capacity. Council of Ministers are very shortly going to be making some prioritisation decisions around the whole legislation programme. They have the legislation programme is a list of all the legislative projects that the ministers would like to deliver in the term. The projects on that list currently outstrip the available law drafting capacity and resource. So there are also some prioritisation decisions, which would mean that even if I had a policy officer working on termination of pregnancy today, we might not be able to deliver that work in a timely fashion because there are two hurdles there.
Did it previously have law drafting time booked in, as it were?
No, it's slightly more complicated than that because, of course, when a new government forms, a new government has aspirations as to the legislation it wants to bring forward, and some of that falls by the wayside, some of it takes longer, some of it takes less time. States members come in with reports and propositions, which change matters as well. So it's always very difficult at the beginning of government to say, what are all the things we want to do? Have we got the resource to do it? So it's always a changing initiative timeframe.
And that, say, Women's Health Policy Officer, what level, what grade do they work at? The previous officer was a grade 12, and it is a piece of work which would require a grade 12 officer. So that's approximately, with on costs, around £100,000 a year. Okay.
She was really excellent, but unfortunately Social Security have nabbed her.
I hope you don't mind, we've majored on this, but I wanted to make it public that it's not just cancellation at a whim, that we just decided that's not a priority. I just wanted you to understand the complexity of the situation that we're facing in order to try and prioritise what we're doing. So I hope you don't mind.
So,
I think it was worth.
To be honest, when I started, I was, very much going to carry on immediately, but circumstances have changed.
So thank you, and that detail is really helpful. I'd like to just dig a bit deeper on, you said something, Ruth, about it's the way that the axe fell. So what I'd like to understand now is the kind of political dominoes that led to this. And was it, you said it wasn't I think, Ruth, you said it wasn't a conscious thing, and Minister, you've reiterated that it wasn't something that you decided to cut.
No.
So therefore it was an accidental or an unconscious kind of, it wasn't an intentional thing to happen.
No.
But can I ask, if it wasn't intentional on your part, would anyone in the wider Council of Ministers, I don't know where that policy came from, would anyone have been aware of this when the policy to not fill vacant posts was set?
I think you'd probably be a little bit more familiar with what happened
So
in the framework of the employment circumstances, but I'll come back to parts of it.
I can't really speak to that. I wasn't privy to the conversations that were had, which resulted in the decisions that we would not recruit to vacant posts.
Okay, and that's from around Com. Whose decision was that?
Well, as you know, I think as a council minister, there's been an attempt to try and cut the cost of government overall, and everything has been squeezed. And I think they've tried to do it in equal measure, and that's the situation in which we found ourselves.
And was that a decision from the Chief Minister then that was cascaded?
It's a council minister's decision to try and keep spending to a minimum and make savings. And you can't have it always round. If you want all the people that you want, that you need, it costs you more money. And that's quite simple. And as Ruth has just said, if we had the money, we probably couldn't recruit the people because the skill set just isn't available. So it's a double-edged sword, really.
How many policy officers does Health have?
My team, Health Policy, we have 5 of us at the moment, and one of the members of the team is leaving in November because they are moving back to the UK.
And they also won't be replaced?
They, as matters stand at the moment, they also won't be replaced.
So you've gone down from 6 to 4? Okay.
So, Minister, what I would like to understand is, in terms of you advocating for your department, what does that look like? Do you go to Com and say, actually, we need this resource?
I have to be careful how often I go to Com and what I ask for. The last time I sat there, I was trying to justify an extra £24 million for the budget. So sometimes you have to take a bit of a beating and move on. I can't complain about everything all the time.
Can I just say that we really appreciate the excellent team that we do have and how
Fair
much we
comment.
value them.
Very much so.
You know, we really, they're invaluable.
In terms of, just to go back to that, in terms of advocating, and it wouldn't be a complaint, would it? It would be a request.
Yeah.
Do you feel that there should be an exemption for something this critical, given the level of public interest in this issue around women's health? Do you think that there should be an exemption for your department and that those vacant posts should be filled?
That'd be lovely. All I would say is that timing's important in these things, and you don't always try and make demands all at the same time. So let's see how we progress, and if circumstances could permit over the course of time, let's see how things go.
So
I'd love to see more support for the team because they're under real pressure.
Okay.
Real pressure.
Okay, please keep us updated if you do seek that exemption.
And if you know of anybody who's got a budget surplus anywhere, we'd happily remove it for them and invest it here because it's needed.
Just one last point on the policy officers. I find it quite interesting how it works, and with SPPP sitting in Cabinet Office as well. Do they have policy support that departments can draw on, or do they have specific tasks that they have to focus on, and you can't, for example, bid for time of half a policy officer's time for the next 6 months to work on a project?
Something I can't answer, but I think Ruth probably could.
So the health policy team is part of SPPP, and we're not part of the health department. And the way it broadly works is that every minister has a number of policy officers dedicated to their area of work. Those policy officers do move around between ministers, depending on demand and depending on whether or not they are fully occupied in the policy portfolio for that particular minister. So an example would be that there is a policy officer who sits in a different team, not in the health policy team, who is leading a policy project on behalf, a legislative policy project on behalf of the Minister, which is about the registration of health and care professionals. So there absolutely is a sharing of resources as capacity allows.
Great. And Minister, in which case have you asked if there is capacity within cross-government for somebody to take on this work?
I've asked if the team could be bolstered, and the initial response was not at this point. So it's something I shall keep my eye on, and if I can change that situation, I will.
Thank you.
So it's possible that the work might be picked up again.
Well, I
Next
can't make
year.
I certainly can't make any open promise to that at all. I'm not in a position to do that, but you can rest assured that I'm very keen to see as much support as I can for the team, because they are under too much pressure in my
So
view.
you can't promise, but you are going to try to
yes,
achieve
as
that.
I say, it's about timing.
The Minister has already,
Yeah.
has already tried.
We'll see how we go.
Thank you.
There was a piece of work also that we were told about a couple of when these discussions were first ongoing about the women's health strategy stopping, but there were certain streams that would continue, but a few things were delayed because of policy officers. One of them was the contraception work stream. Could you give us an update about where that is at, please?
Yes, certainly. So we did a contraception use survey over the summer. We hopefully next week we'll be publishing the feedback report of that. And I'm quite happy to tell you kind of some of the key findings of that at the moment. So, that report told us some interesting things about women's access to contraception. One of the key questions that we were asking in that report was whether or not women were able to access and use their contraception of choice, because anecdotally we have been told that it could be very difficult for some women. Overwhelmingly, the majority of women who responded to the survey said, yes, they are using their contraception of choice. Where that's not necessarily the case is in the younger age groups. And what the younger age groups were saying is, not that I'm not using my contraception of choice, I don't actually have enough access to information and support to make a decision about what contraception I want to be use and what is the best contraception for me. One of the overwhelming findings of that report was that women who use the contraceptive pill want to be able to access that contraceptive pill from community pharmacists without having to go via the GP or without having to go through the Bar Centre. Those arrangements that have been brought forward in the UK, and there's really very clear demand for that. So we will be looking at that as well. The issue of cost did come up in the feedback, but actually it wasn't necessarily a priority issue. When we asked women why they go to their particular provider to use contraception, it was very often issues about, I can park outside and there's appointments available at the time I need them, which is outside conventional working hours. So cost is not necessarily a driving factor for for why women use the services that they use.
Okay. So the policy work that will flow from that's got resource and that will continue?
So the policy work that will flow from that is going to continue, but it is not going to continue at the pace at which it was planned. And that is because that missing policy officer from my team, as well as doing termination of pregnancy, was also doing work around contraception. I have found alternative ways to try and progress the contraception piece of work because it's not such a large piece of work.
Great, thank you.
Yes, please do.
So, Minister, you recently published the IVF access criteria, and you have put £620,000 in the budget for that. On what basis did you come up with that figure, and are you confident that that will meet the demand for the service?
I'm reluctant to use the word hopeful again, but I'm going to. I am hopeful that that will meet the demand. It had to be as accurate a guess as we could make. Got to hand you back to Ruth because it was quite a complicated process that sat behind it. So Ruth will
I
give you a
think there
chat.
was a very clear business case from the policy.
What I'm trying to get at is, was this a financially driven decision?
No,
Or
well,
was
it
this
was,
a need
but
decision?
a little bit of both. It was against a formula, looking at other areas as well, and trying to come up with something that didn't put too much financial. Obviously, the more money you've got, the more you can do. But I think we would have come up with something that would be a manageable amount of money against sensible criteria. But I'll hand over to Ruth to map. Ruth can map out that criteria much more accurately than I can.
So we have gone through a process of mapping what we anticipate the effects of different criteria would be in terms of the resources that are required. As far as we can work out, and I do say as far as we can work out, we think that the 620,000 that's provided in the government plan should be sufficient. My hesitancy is because there is something very important that we just don't know, which is about latent demand for IVF services in Jersey. We have got no way of modelling that at all. So we put £600,000 in, £620,000 in, we put criteria in. The other thing that's really important is that we have set up a new system which will come into place on the 1st of January when the new child criteria come into place, which is about modelling uptake of IVF services in real time, so that if we get to the point where we think one of two things, either we are not going to be able to afford that service into the future, that then provides the minister with an opportunity to bid for more money through the government plan, or to tighten the criteria to actually drive down the flow put, or if we've got sufficient money in, to do exactly the opposite, which is to extend the criteria so more women would be available. And the other thing is alongside that is our lead consultant for the assisted reproduction unit, because he knows that this additional money is coming, so therefore, for want of a better description, the Jersey market for IVF is larger. That has given him the ability to start to go to UK provider clinics to talk to them about what purchase of services at a lower unit cost would look like, which would help us either manage cost or help us provide more IVF to more people.
So if the money runs out because demand exceeds the budget, will that mean that people will simply not be able to access the service, or will you have spotted that in advance and taken measures to throttle demand, or what? What will happen?
I think it's a case of monitoring as we go forward. As we come through the year, we'll be able to map out where we think we're going to be and a number of different options. We can come back and try and get some more money if we can, which I think under the circumstances will be very difficult. It could be that you actually bring things to a close and start again in the next financial year and carry forward that requirement. As I say, what we've tried to do is set it at a level that, given all the thinking that's gone into this, that it should just about do the job. But we won't know that until the process starts.
And one of the things that I think is quite important is transparency in this process. So we know that much is made of the fact that NHS Scotland provides IVF for all women who meet the criteria with no financial caps associated with it at all. But the actual reality is that waiting lists in Scotland are so long for IVF that even though couples are entitled to NHS-funded IVF, they actually purchase it privately because the waiting lists are too long. So one of the things that we are aware of is we need to really monitor IVF provision, and we need to be open and transparent about if we need to amend the criteria, why we're amending the criteria, rather than just retaining criteria and pushing people into the never and ever of waiting list land.
If the capacity is able to be met with the current criteria and you can look to expand the criteria, would you consider expanding it to include same-sex female couples who currently face higher costs because they're required to have IUI before they can access IVF?
We had a discussion about that actually about 2 hours ago, and it's got to be one of the things that we'd bring back to the frame. It's not something I can make an absolute commitment to, but it's certainly something we'd be happy to discuss. We discussed it earlier today.
Yeah, I think we just have to see how the funding pans out, really.
In which case, will you be keeping data for those not just who qualify, but who don't qualify? I know they may not all make it to you, but it seems that in the building of all of this, I think we all acknowledge the data hasn't been great, has it? At one stage, I don't think we even had a number of live births that were due to IVF kept in Jersey. Stronger data has surely got to be a good thing.
Where we know, where people come to our front
Yeah.
door, even if we say sorry at that front door, we will obviously keep track of that. But obviously there'll be all the unknowns. So all the people who don't meet the criteria, so don't come to our front door.
Yes, absolutely. Okay. And can I just ask a quick question? Well, if it will be quick, but around the new criteria, obviously removes the existing system, which currently pays for the drug funding for more or less everybody under a certain age. So there are some people who are going to be worse off under the new system. For example, people who've already got previous children, including if they're stepchildren that they've never lived with or cared for themselves, but their partner did. That funding that is previously been spent on their drugs, is that being added to the 620, or where's it going?
So as part of the modelling work, what we looked at is we looked at the monies that were currently available in the service, and obviously one of them, those pots of monies is the monies that were spent for medication. We anticipate that in terms of the numbers of people who meet the criteria, that will be over 620,000, but that there is enough money in the existing current budget through doing things like not providing medication to everybody to be able to fund IVF, including the medication, for everyone who meets the criteria. So you are right, there is a group of people who have lost out because those people don't meet the criteria.
But the money is not, ARU's budget isn't being reduced. No. The whole 620 is in addition to ARU's budget.
Yes.
Okay, thank you.
Okay, thank you. In terms of women's health, there's a related area. I'm not sure if it's the Social Security Minister or if it's your team leading on the period products scheme.
I think it's the Social Security Minister who's leading on this, and she's going to give us an update next week. But I do think they're now at multiple locations around the island, but I think they've taken away them from men's toilets.
Okay. Is there any further updates you can give at this time?
I won't know till next week, I'm afraid.
Okay, thank you. Anything else on women's health? No?
Just to say, we are taking women's health very serious, and we've got actions in train.
Great, thank you. I'm going to ask a final question on assisted dying. Thank you for the law drafting instructions which you shared with the Assisted Dying Review Panel, which is the other panel that I chair. Could you give us a brief outline on the timescales that you're working to for this piece of work?
Ruth, be better able to.
Oh, sorry, you've caught me slightly on the hop.
Was that unexpected?
Yes. As you know, you have a draft of the law drafting instructions. The law drafting officer also have. They are starting work on it, but obviously we won't formally issue them till we've had feedback from the Assisted Dying Review Panel. There are some parts of the instructions that we're working on, some very specific work around law drafting instructions for the matters such as offences and protection for health and care professionals. They will be issued to the panel probably on Monday, and to the law drafting officers. And at the front of the instructions, there is a timetable that sets out when we anticipate bringing the draft law to the Assembly. I cannot remember the date, but that is the date, and we are on target for it.
Okay, all right, thank you. Sorry, I did throw that one in there. Okay, did the panel want to add any other questions? Okay, Minister, is there anything, or Assistant Minister, anything final that you would like to add before I close the hearing?
No, I don't think so.
Just say thank you very much.
Thank you.
Well, thank you very much for attending the hearing today, and thank you to your officers who have all provided really helpful information. We appreciate your time, and thank you to everybody who watched the hearing today. And I'll close the hearing. Thank you.
Thank you.